Good morning, everybody. We're glad to have you here today. We're going to talk about the case of mysterious strokes, and here's multiple strokes in this patient. Here's Sherlock Holmes, who's examining this brain and finding two areas that appear to be strokes. That one is superficial and one's deep, look parietal. And so let's see what's going on here and see what we can find out about the mystery case. So we'll get started and tell you about this lady, a very nice lady who basically is a 55-year-old female school teacher who lives in Plant City. She was vacationing in North Carolina in Waynesville, Maggie Valley area, and she had this 30-minute episode of her right arm jerking, some leg weakness on the right side, slurred speech, and went to Hayward County Hospital and was seen by the cardiologist there, admitted to the hospital, and had a workup, including transesophageal echo and transthoracic echo. Nothing was found other than the fact that on her MRI she had a stroke, and she was discharged home on an aspirin a day without a diagnosis other than cryptogenic stroke. So this is something we run into all the time, and she certainly got a welcome approach to care. I know the cardiologist there and Hayward County Hospital, and they did a very good job. They did a good workup. We got some of their stuff here we can show. And so she denied any symptoms when she came to our clinic and was doing fine, had no further episodes, but was very concerned. She was sent by her doctor in Plant City to see if we could review and figure out what's going on. And so she has a history of some migraines, insomnia, cystic breast disease where they have to have aspirations. She's got hysterectomy. Her father is deceased. Looks like her whole family's deceased. Her father's deceased at 86, diabetes, hypertension, cardiovascular disease, and strokes. Mother passed away from a stroke, 82, had diabetes and hypertension. Brother died of 57, congenital heart defect. Sister died at 58, hypertension. So the whole family has died off, and some of which is stroke-related, mother and father. So this is certainly alarming to the patient that she's now had a stroke, and her family, two of her patients, two of the people in her family died of strokes. So lifestyle is sedentary, allergies none. She's on her baby aspirin and some other medications for sleep and for anxiety. So she did get a CT of her head that showed some white matter changes, presumably secondary small vessel ischemic disease. And she also had an MRI of her head that showed two acute small abnormal foci restricted diffusion, which deep frontal parietal, white matter, and left parietal cortex. And then there were numerous foci with solitary and coalescing abnormal white matter signals suggestive of small vessel ischemic disease, which is so common, and then no intracranial mass was present. So we can show you some of our images. If you hang on here for just a minute, we'll get our images up. We're going to scroll through this a little bit and look at our echo. Maybe Pooh can comment on the echo as we scroll through.
Sure. So we have a apical four-chamber view. Some of the five chambers, wisps of AI, nothing standing out so far. Our concerns would be with cryptogenic stroke, either PFO, aortic atheroma in the PE, or left atrial appendage clot. So those are the three things I'm looking for. EF's pretty good. Don't see the LV apex too well. Just let us
So it looks pretty good, doesn't it, Pooh?
Yeah.
So I've got one little question here. We can see if we can run it backwards. We got one here. Let's see if I can get this to go back where we were and go forward again. Oh, here we can interrogate the atrial septum pretty well there. And so there's a good interrogation for, they're not doing a Valsalva, are not doing bubbles. Maybe they're waiting for the TEE to do that. But they are getting a pretty good look at the atrial septum. Let's see if we can go back to one little area back here that was questionable. And here we are almost there. So let's play this forward and see how this looks. We'll wait till we get to the color. And so when we get to the color, there's a question there about whether there's a little ventricular septal defect. See that, Pooh?
Yeah, I do.
Yeah, this was not read in the study, was not interpreted as a ventricular septal defect, but it's in the membranous septum, and it looks like a tiny ventricular septal defect.
Yeah, maybe TE might help us, or a bubble study to see negative contrast.
Okay, let's go take a look at the TEE then. Okay, here we go for our TEE. So tell us what you think about this, Pooh, as we get it slowed down a little bit. We'll see what we can show you. Want to describe what you see?
So this, we're coming like we're at 30 or 40 degrees. It's 4 chambers, still trying to go towards 2 chamber. So far, I don't see a VSD. With my short axis for the TE would help, maybe.
Looks like we've got bubble
Yeah,
out here.
Study, yeah.
Oops. Let's go back to, looks like an alien popped in here while we're doing this. But it looks like we've got bubbles coming in.
Yeah, and some degree of negative contrast.
Oh, there's the left atrial appendage.
It looks, I mean, you can turn the gain down, but it looks like overall clean. I don't see the numbers. And this some smoke. So enjoy your septum.
We're going to go forward again a little bit. We'll go back to the bubbles. Oops.
Yeah.
What's that?
So this they're looking for an aortic heteroma.
Yeah, the aorta looks clean. Looks like a clean aorta, doesn't it?
Yeah, no, not much calcification. Usually short axis is pretty good, like 9 to 12 would be membranous and 12 to 3 would be outlet.
Yeah, here's a little short axis there for a minute.
40-ish.
There's some more color. Let's see what we see on this. So when they injected the bubbles, I didn't see any bubbles going from right to left. Here we go. Let's look at the bubbles again. But I don't know if they're valsalving. Probably not, because the patient is sedated. There's the alien again.
And we should see some negative contrast. It's pretty hard to appreciate the picture.
So how would you grade the study overall in terms of quality?
Fair.
Actually, it doesn't look as good as our transthoracic echo that we do. Looks very fuzzy. It's not what you expect for a transesophageal echo. It's too much magnification, not enough sort of guided, not enough guided imaging, getting what you want, getting in and getting out.
Yeah, the gains are too high.
Yeah, so nothing here of any note, correct? As far as we can tell.
True, yes.
So let's go to the next thing here. We'll get back to it. Whoa. Get back to our slides. All right, so we've done the previous workup. And it showed a tiny VSD in the membranous septum that hadn't been realized. That wasn't realized, and it's not wasn't on the report. So we found a ventricular defect, tiny one. And so left ventricular ejection fraction normal, no wall motion abnormality. Again, the same. No evidence of atrial septal defect or ventricular septal defect, but we really didn't interrogate for that. A bubble study was negative for right to left shunt. Didn't see any bubbles, but the patient was sedated. And so you got to do the bubble study with the transthoracic echo before you sedate them. There's a protocol for that. And you can do that very easily and get them to do Valsalva and look and see if you got bubbles, because you're sure not going to see much going on if you just do a TEE and the patient's sedated. So we didn't do this right. We'll say that wasn't done right. And there's a protocol, basically, that you can give the techs. I give it to them every year because it gets filed under miscellaneous and we never can find it again. And the protocol works for a while and then it's disregarded. And basically what you're doing is you're doing a conscious transthoracic echo with bubbles with Valsalva maneuver. And that's pretty much pretty important. And then possible thickening of the heart valves, well, maybe. Mild MR, because we're always worried about morantic or non-bacterial endocarditis. And so we worry about that. Mild MR and TR, moderate atherosclerotic plaque in the aortic arch. Well, I'm not sure about that. I didn't see much. So that was their report, though. Mild atherosclerotic plaque in the descending aorta, I don't think so. I didn't see all that. So didn't see any calcification. I didn't see any plaque there. So much for that. So now, previous workup, I'm going backwards. And physical examination, when we saw her, everything was fine. We did not hear a maladie de Roget. There is a murmur that you can hear, the maladie de Roget, which was described by Dr. Roget, a Frenchman, who basically described a very loud murmur with a very, very tiny ventricular septal defect. But I don't hear it, so that's out. Everything was a fine order physical examination. And so our plan was this. We were saying Arrhythmia, perhaps. Atrial fibrillation is so common as a cause of cryptogenic stroke. So let's go take a look at that, see if there's any missed atrial fibrillation. You got to do a lot of monitoring. Sometimes you even wind up putting a reveal in. I didn't see atrial atony, and I have had people that we've done a TE and found atrial atony, and atrial atony means that the left atrium's not moving, although it's some patient's in a sinus rhythm. So that means that the patient had a stunned left atrium and was going in and out of atrial fibrillation. Even though atrial fibrillation wasn't evident at the time, basically the atrium wasn't contracting, and so you knew that patient had been in atrial fibrillation, it had just been missed. And so we're going to do a cardiac event monitor. How about collagen vascular disease? Maybe that's a cause of merantic endocarditis, so maybe we ought to do some kind of little survey for that, make sure they don't have some kind of underlying cancer or collagen vascular disease. So we said, well, we'll do a quick screen on that, and so there's some of our screening tests. And hypercoagulability, well, if you have a ventricular septal defect or an atrial septal defect, you got to have a clot before you can get something that can flip across. Although you could have with a ventricular septal defect, when they seal off on their own, they get this little windsock deformity that looks like one of those windsocks at the airport, but there's a hole in it, and then finally it seals off. And so that's how they seal off. And by the age of 2, most congenital ventricular septal defects, which are considered very benign, have healed up themselves and occluded themselves. And so that's done with development of some tissue in the area of the ventricular septal defect, and the tissue proliferates and it forms this little windsock thing. The windsock is obviously going from left to right, and but you can get infection on the windsock, and you can get a ventricular septal defect jet lesion that can be a site for endocarditis. That would be somewhere on the right ventricular wall opposite the jet from the ventricular septal defect. And so that would be on the right ventricle wall, or you can get infection of that windsock. And so those are all possibilities. Non-bacterial thrombotic endocarditis, we should look for that with a cardiac MRI. Perhaps we can see something on the echo, look at those valves and see if they're abnormal. So this is kind of what we decided to do in our workup, and already we know there's a ventricular septal defect, which we wouldn't have known by the reports, so I'm glad we got the images to look at. We did do the cardiac event monitor, and we did not find atrial fibrillation. We probably monitored for a couple of weeks, and this is all we got. This doesn't mean the patient's not having atrial fibrillation, and I have a gentleman that I saw his atrial fibrillation on yesterday that has been monitored ad nauseum, but has a familial history of atrial fibrillation and has a lot of PACs and PVCs, and we finally called atrial fib on him. And so 2 of his family members have atrial fib, and it could be that he's probably genetic. You don't need to actually test for it, although there are 2 genes that seem to promote atrial fib when they're mutated, and there's 1 gene that seems to prevent atrial fib when it's mutated. So 2 up and 1 down perhaps. And so carotid Doppler, looking for a carotid plaque, no plaque. And so no carotid plaque. You wouldn't think she would have atherosclerosis of the aortic arch or the transverse aortic arch, which was reported in the TEE. It was reported, and I didn't see that. And so I think this is an overread. So that makes you start thinking about how good this study really was. If someone believes that there's moderate aortic plaque in that aorta, no carotid plaque, I don't believe that's true. So I don't think that's there either. So transthoracic echo. Let's look at our transthoracic echo and see what that shows. So hang on. So Pooh, tell us about this particular study. This is a transthoracic echo.
So 5-chamber endocardial border definition is so much better here.
Yeah, doesn't it look so much better? You can see if you got the right equipment, which hospitals usually don't want to buy the right equipment because it costs too much money. And most people in their office get used equipment. But you can get used equipment that's top of the line if you want to do that. But if you get the right equipment, you can. This looks actually better than the esophageal echo. It looks more detailed. It's a much better study. So this is a top-of-the-line GEs shipped in from Norway.
Okay, now we're interrogating the septum.
So obviously we're looking for the ventricular defect we're looking for there. Interrogating. I'm not sure how well we see the septum.
It's hard to comment, but I don't see any obvious ripples. Left to right. There's a dropout. I'm not sure if it's because it's not aligned properly or if it's a genuine true VSD.
I'll try to move it along here a little bit. So we're looking for merantic endocarditis. Looking at the aortic valve leaflets to see if they look thick or not. Tricuspid looks good.
Every function is good.
Looks like that's the end of the line. Let's go backwards.
Parasternal long axis, I thought I saw before something across the septum, but I wasn't positive.
So we got to back up again, and this is the area we would be looking at. We'd be looking down in there to see, one, if we see a windsock, and looking at the membranous septum to see if there's a tiny hole there. We should see shunting from left to right, if that's true. And I think we did see that somewhere along the line, but I don't see it particularly right here. I can't see that in there. But obviously we'd have to have bidirectional shunting if we're going to be able to say that this is responsible for the patient's strokes, unless there's a windsock sticking out into the left ventricular side, which I don't see, and unless that got some platelets stuck on it or something. There we go. Looks like we've got a little shooting jet there. Tiny little shooting jet. That's going towards the transducer, therefore it should be red or orange. So there's our jet. We can't see any more than that jet there. So we do have a jet that's showing up right there. And then there's a little dropout. See the dropout? A little dropout in that area. So we're hypothesizing that there's a ventricular defect, and we're saying we must have had some right to left shunting. Can we prove that? Well, let's go back and let's take a look at our MRI next, and then we'll go back and decide what we've got here. So let's go do that. Hang on. Yeah, so we'll start our MRI sequence. And so the first thing that Tuan does when he does this, or Al, is they do a survey. And so basically the survey is defining the anatomy, centralizing the heart, and doing sagittal, coronal, and axial to find out exactly where our targets are. And so that's what they're doing here, to identify the targets, find out the patient's rhythm, see what we can look at. And so that's it. We've got it right here. So that gets us sort of localizing what we want to see. The next thing we do usually is a black blood study. So the circulation is going to be black. And so we're going to look at this and look at morphology. So this is the right atrium. There's the left atrium, interatrial septum, left ventricle, right ventricle. And so we sort of find the lay of the land with this study, and we look at things to make sure everything's in its place. And so we look at the pulmonary artery, look at the aorta, we look at the ascending aorta, pulmonary artery bifurcation. We're looking at size, structure, ascending aorta, transverse aortic arch. This is as high as we went. See the trachea, see the trachea bifurcating. And then we get down here, we usually see coronary origins. Looks like a left anterior descending, turning the corner there. Usually we see the right somewhere over here. Sometimes we see the bifurcation and the main left origin. And then we can do measurements on the left ventricle if we want to. And so the anatomy appears to be normal. Look at the pericardium. So it looks like good anatomy. So we're happy with that. So then we can go on to the next piece. And the next piece looks like it's a sagittal LV-gram. So let's take a look at the sagittal LV-gram. Pooh, any comments on the sagittal LV-gram?
I mean, there's maybe tiny AI, but
yeah, we'll find out more when we get into those images. So let's take a look at the next image. So now you can comment on this one.
some MR, some AI. LV functions pretty good. It's contracting well. So we'd want to see a VSD. Septum.
So we can look in this membranous septum pretty well here, and we can see there's like something in there somehow. That could be the windsock, that little light stuff. See the little light stuff just superior to the ventricoseptal on the right ventricular side. So that could be a windsock deformity there. It's not very distinct. We don't have the kind of resolution we need to be able to see that. With MRI, you just can't quite get there, you know. But the TE is usually one thing we trust for being able to interrogate that closer. But there is something there that looks abnormal, and that's the best I can do. Can't see any streaming. And actually what you want to do, there's something you can do where you make, you nullify a whole half of the heart if you make it null. And then you can see if there's a left or right shunt, you can see stuff pumping across the nulled area. So there is a way of creating a really beautiful image of a shunt by nullifying a whole half of the heart, making it black, and then seeing stuff just popping across that's white. And so so that's a possibility. I haven't seen it done much, but it's done with congenital heart disease. And so it's a technique that you can use. And so here's a 4-chamber view. Atrial septum's got a little wiggle to it. You can't tell much about the interventricular septum there. Things look like they're moving pretty good. We can get some more magnification in there. It just gets blurry when you do that. So I can't tell much about that with this. Just gets a little blurry. And so we lose definition by doing that. Beautiful images. Very, very pretty. No significant AI. This has got some motion artifact, but that looks pretty good. Looks like we're doing a contrast study. So let's take a look at our contrast study. And it looks like we need to decrease the gain so we can see the contrast coming across the ventricular wall. Decrease the gain a little bit more. And so this is a study that's done to understand myocardial perfusion. So you can do this with Lexiscan or Persantin, dobutamine, and get very nice pictures. And so it's more accurate than SPECT scanning, but everything's more accurate than SPECT scanning. So let's go look at, we're focusing on this little area of dropout of the interventricular septum. And we're going to interrogate it a little bit. So there's our ventricoseptal defect that's going from right to left. There it is again. And here we go. We've got blue during diastole, which means this is wafting across the ventricular septal defect during diastole and going away from the transducer. And so we were able to pick up that there is very transient shunting from right to left. There's this little tiny bow tie there. So it's shunting from right to left without the patient doing anything. Just lying there, breathing. There it is, right there. Do you see that, Pooh?
I do.
That's pretty cool. So we went back to the echo lab to try to get some very specific characterization of the ventricular defect, and there it is. We've been able to demonstrate that it shunts from right to left. We've not been able to find a coagulopathy in this patient, although we did a coagulopathy workup. We've not been able to demonstrate DVT, but the patient did travel to North Carolina, so had made a trip, and then had gotten there, and then at some point developed this neurological symptoms, went to the hospital, had the workup, ventricular defect not seen, imaginary atherosclerosis of the ascending and transverse aortic arch, and that was about it. And then down here to see us, ventricular defect seen on the previous study, nothing seen on the TEE, no moranic endocarditis, cultures, no bacteria endocarditis, SED rate normal, no collagen vascular disease, CA-125, no evidence of any underlying ovarian cancer, and basically, again, no bacteria or moranic endocarditis, ventricular defect, shunting, and shown to shunt from right to left during diastole. Very interesting. So now we sort of nailed this down, and how would you treat this patient? Pooh, you got any ideas about, would you go with just Plavix and aspirin, or just aspirin, or would you consider Eliquis? I mean, this is a pretty serious thing to have two little focal strokes there. Lady's terrified, especially given the fact that her mom and dad both died of strokes, and her brother and sister are dead.
I mean, anticoagulation is not unreasonable. Eliquis like MS, or if she had AFib, we would have done regardless. It's there. I mean, useful.
So we haven't proven AFib, but
She doesn't.
Yeah, I do believe that, you know, she still could have AFib, but I do believe that she had, just by history, you know, must have had a clot from traveling, and then must have shunted that from right to left. And so basically we decided to start her on Eliquis for a while, and then decide where we're going and review the literature. And Hassan has done a literature review. Let's see what Hassan has to say about that. Hassan?
Well, all I could find was basically just some case reports about it. And I just got this one from '89, so a long time ago, and they looked at cerebral infarction in someone who had a VSD. And at that time, they said this is the first time something like this has been reported. There's also another, I guess this is a bigger literature review sort of, and they mentioned some splenic infarctions, which was the result of paradoxical emboli in someone who had a perimembranous VSD. But then they also had Eisenmenger syndrome. So just a few case reports, nothing more than that. And in theory, they do say that besides the foraminal valley, a VSD can potentially do it, but I think it's just some reported cases, nothing more than that to actually say what, how much it actually contributes to stroke or something like that.
So that concludes our review today of ventricular septal defect occurring in someone with cryptogenic stroke who basically has no reason to have a stroke that we would know of, that we could find, who traveled to North Carolina and then shortly thereafter developed that. No evidence of a coagulopathy abnormality in what cursorily we performed, and no evidence of endocarditis, moranic carditis. We didn't see any infection site on a windsock that is involved usually in healing or closing of ventricular septal defect. Usually there's an associated windsock, and we didn't find, that's a proliferation of tissue that's involved in that healing. So we didn't see anything there, and so with the ventricular septal defect, we were able to show at the end that there was some shunting from right to left during diastole. I think that was the clincher, that we were able to demonstrate that. The literature, 2 cases is all we see in the literature, kind of amazing. And so We did put her on Eliquis. I'm not sure that's the right thing to do. She was on aspirin. I am convinced that with the travel history and so forth, that that's a good thing to do. We do have people with patent foraminal valley who have the same history, who we treat with anticoagulation first as a first option, and then wait to see if they have any recurrence or not. And then on those people, there is some pretty strong data about closure decreasing the risk of having another event. In this particular case, we're not considering closure. I think that would be a pretty drastic thing to do in this lady at this time. And so, and the only reason would be if she had had a stroke. And so if she has recurrent cerebral vascular symptoms, recurrent episodes that we might see as a stroke, or TIAs, at that point, then we would consider a closure procedure. Here's a little like windsock deformity that you can see in there on the ventricular septum on this particular patient. And so frequently you do see some tissue proliferating in that area. And so these are people with larger defects. And you can find the literature frequently mentioning that there could be a paradoxical embolus, but obviously 2 reported cases. So thank you very much. We enjoyed talking today, and very, very interesting case. Thanks for being there for us to share it with you. I'll see you next week. Bye-bye.
Thank you.
Bye, Pooh. Bye, Janine. Bye, Largo Group.